7 for more information on this. Ideally, an EEG should be done within 24 hours of a suspected seizure. Abnormal findings help determine the type of seizure and help pinpoint the seizure focus. Only a small percentage of patients with seizure disorders have abnormal findings on an EEG the first time the test is done. So I'll repeat that. Only a small percentage of patients with seizure disorders have abnormal findings on the EEG the first time the test is done. Either repeated EEG or continuous EEG monitoring may be needed to detect abnormalities. An EEG is not a definitive test because some patients who do not have seizure disorders have abnormal patterns on their EEGs, whereas many patients with seizure disorders have normal EEGs between seizures. If abnormal discharges do not occur during the 30 to 40-minute sampling taken during the EEG, the test may not indicate an abnormality. Diagnostic studies continued. So the magnetoencephalogram with conjunction EEG offers a greater sensitivity for detecting small magnetic fields generated by neural activity. A CBC should be done, serum chemistries, liver and kidney functions, a UA to rule out metabolic disorder should also be completed. Why is this important? Because without fixing the underlying causes, the seizures will continue. So identifying those metabolic disorders will stop the seizures from happening. Continued diagnostic studies are CT or MRI and new onset seizure to rule out structural lesions or a tumor, cerebral angiography, SPECT, MRS, MRA, and PET in selected situations. Most seizures do not require emergency medical care because they are self-limiting and rarely cause bodily injury. Immediate medical care if status epilepticus occurs, significant bodily harm occurs, or the event is a first-time seizure for a patient. There's a table in your textbook 59-8 that summarizes emergency care of the patient with a generalized tonic-clonic seizure, the seizure most likely to warrant professional emergency medical care. Diagnostic studies and collaborative care of seizure disorders are outlined in table 59-7. Continuing with collaborative care, seizure disorders are primarily treated with anti-seizure drugs. The goal of therapy is preventing seizures with minimum toxic side effects from drugs. Medications control seizures in about 70% of patients. Drugs act by stabilizing nerve cell membranes and preventing spread of the epileptic discharge. About a third of patients require a combination regimen for adequate control. Therapeutic drug ranges are guidelines. Serum drug levels can be helpful. So there's a lot of information going on with this slide. We're going to start just by tackling it one thing at a time here. So the principle of drug therapy is to begin with a single drug based on patient age, weight, type, frequency, and cause of seizure, and increase the dosage until the seizures are controlled or toxic side effects occur. If seizure control is not achieved with a single drug, the drug dosage or timing of administration may be changed or a second drug may be added. Seizure control is a balancing act. Let me say that again. Seizure control is a balancing act. You want to use the lowest dose of medication. Lowest dose of one medication is optimal. May need to increase the dose of a second medication, etc. The therapeutic range for each drug indicates the serum level above which most patients experience toxic side effects and below which most continue to have seizures. If the patient seizures are well controlled with a subtherapeutic level, the drug dose need not be increased. Likewise, if a drug level is above the therapeutic range and the patient has good seizure control without toxic side effects, the drug dosage does not need to be decreased. Effectiveness of anticonvulsant drug therapy is to maintain seizure frequency, which should be charted. Serum drug levels are monitored if seizures continued to occur, if seizure frequency increases, or if drug compliance is questioned. The data is helpful when making dosage alterations and specific drug selections. Many of the newer drugs do not require drug level monitoring because the therapeutic range is very large. Drugs for seizure disorder must be taken regularly and continuously, often for a lifetime. Teach patients the importance of following the specific drug regimen and what to do if a dose is missed. So abrupt cessation of anticonvulsant drugs increases the risk for status epilepticus. Compliance is the key for these patients. If a dose is missed, the patient should take as soon as they can. If it's almost time for the next dose, wait and take that dose. Do not double up. Primary drugs for the treatment of generalized tonic-clonic and focal seizures. So there's the list there. The most common one there is Dilantin. It is used quite frequently, but you'll see all of them, Depakote, Tegretol, Luminol, all those are seen quite frequently in the hospital. Of the medication listed, phenobarbital or luminol is a barbiturate. All others are anticonvulsants. So it's important on this slide to recognize 1 through 4, the first 4 medications there, but know that phenobarbital is a barbiturate. The barbiturate, the phenobarbital, stimulates GABA receptors, which inhibit neurotransmission. They can cause drowsiness, ataxia, which is uncoordinated movement. There's caution for their use with respiratory depression and hypotension. Therapeutic level is 15 to 40 milligrams per ml. Uses for tonic and clonic or focal seizures or status epilepticus. Anticonvulsants, the other medications listed there, are used to decrease abnormal electrical activity in the brain. They can cause gingival hyperplasia, which is the gums are enlarged and bleed easily, and bone marrow suppression. So it's important for these patients to teach them good mouth care, watch platelets and white blood cell counts. Milk and acids interfere with the absorption of these medications. Use caution if they notice a rash, as this can cause Stevens-Johnson syndrome, which Stevens-Johnson syndrome is acute and life-threatening. It's a mucocutaneous reaction. The mucosa transitions to skin, which affects the lips, nostrils, conjunctiva, urethra, vagina, foreskin, and anus. Excessive necrosis and detachment of the epidermis. If those are any complaints that you see happening with your patient, stop the medication and report immediately. Therapeutic level for the anticonvulsants is 10 to 20 micrograms per ml. Primary drug use to treat absence or myoclonic seizures are the Depakote, Serotonin, and Klonopin. Some of these drugs are broad spectrum and appear to be effective for multiple seizure types. It's important to recognize the second and third one there, the Depakote and Klonopin. Depakote is valproic acid. So with that medication, it is important to monitor the liver function, white blood cell counts, platelets, and they can cause GI issues with the Depakote. Collaborative care for broad spectrum drugs can be effective for multiple seizure types. So these are another list of medications used quite frequently. Recognize or pay special attention to 1 through 3, the Neurontin, Lamictal, and Topamax, and number 5 there. So that would be the Keppra. Pregabalin or Lyrica, used as an add-on for control of focal seizures that are not successfully managed with a single medication. Lyrica is also used for nerve pain. You may have already heard of it. It treats nerve and muscle pain, used for the treatment of fibromyalgia. Status epilepticus is initially rapid-acting IV lorazepam, Ativan, or diazepam Valium, followed by long-acting drugs to control the activity. Because Ativan and Valium are short-acting drugs, you need to follow their administration with a long-acting drug such as phenytoin or phenobarbital. Benzodiazepines such as lorazepam, Ativan, or diazepam Valium use status epilepticus because they're fast-acting, so you want to stop the activity, cause increased drowsiness, and impaired liver function. So monitor those patients closely. Tolerance can develop if these medications are given too much and will not be as effective. Reversal agent for these are flumazenil. Many of the anti-seizure drugs have a long half-life. Can be given 1 to 2 times a day. A simplified drug regimen can increase medication compliance. Anti-seizure drugs should not be discontinued abruptly, as this can precipitate seizures. Common side effects involve the CNS and include diplopia, drowsiness, ataxia, and mental slowing. Drugs currently used in seizure management are shown in your textbook on table 59-9. Diplopia is double vision, if you don't remember, and ataxia is impaired balance and coordination. Neurologic assessment involves testing for toxicity. There is nystagmus, hand and gait coordination, cognitive functioning, and general alertness. Non-compliance for these patients is a significant concern. Nystagmus is repetitive and voluntary eye movements. You need to be knowledgeable about these side effects so that patients can be informed and institute proper treatment. A common side effect of phenytoin is gingival hyperplasia, which we discussed earlier, which is the excessive growth of gingival tissue, and hirsutism, which is excessive body hair where hair is normally absent, especially in younger adults. Medication non-adherence can be problem in persons with seizure disorder. Take measures to increase patient adherence to the prescribed drug regimens. If made aware of the issue, healthcare providers can work with the patient to find an acceptable drug regimen. Back to our case study. So, what are hallmark symptoms of WL's complex focal seizure? If you remember, he displayed lip smacking and grimacing. Number 2, what patient teaching should you do with him? It's important to teach WL about what to expect in the future seizure episodes and possible treatments. He should also be taught to avoid possible triggering factors such as lack of sleep and too much alcohol. He will need information about resources and follow-up care, so have that ready to go over with him. Collaborative care continued. Gerontologic considerations. The incidence of new onset seizures disorders is high among older adults. Carefully consider the relationship between the action of the anti-seizure drugs and normal changes that occur with aging. Gerontologic considerations. Phenytoin may be problematic for older adults with compromised liver function. Phenobarbital, Tegretol, myosilene negatively affect cognitive function. Drug interactions with carbamazepine, phenytoin, and phenobarbital. So this is a slide that let me get rid of that next slide thing right there. You'll need to be aware of these considerations. So a 72-year-old patient with a prescription for Dilantin or phenytoin, you'll need to consult with the provider prior to administration if the patient is having elevated liver function tests. So if you notice a Dilantin prescription, you should check the patient's chart to ensure that their liver function is within normal limits and is not elevated. If it is elevated, contact the attending or the primary care doctor immediately, and don't give the medication until they approve. Surgical intervention to remove the epileptic focus or prevent spread of epileptic activity in the brain. Benefits of the surgery are the cessation of the seizure and a reduction in the frequency of the seizures. Anterior temporal lobe resection is the most common surgical intervention. It's a temporal lobectomy. About 70% of patients are essentially seizure-free after this procedure. Not all types of epilepsy will benefit from surgery. An extensive preoperative evaluation is important, including EEG monitoring and other specific tests to ensure precise localization of the focal point. Risk are memory and language problems, temporary double vision, and decreased visual field. Three requirements for surgery have to be met. They have to have a diagnosis of epilepsy confirmed. They have to have an adequate trial with drug therapy without satisfactory results, and electroclinical syndrome defined. So an electroclinical syndrome is a characteristics classified by age at onset, cognitive and developmental antecedents, something that came before something else, or the causes of it, and consequences, motor and sensory exams, EEG features, provoking or triggering factors, and patterns. Vagal nerve stimulation is adjunct to medications when surgery is not feasible. Exact mechanism is not known. Thought to interrupt synchronization of elliptical brain wave activity and stop excessive discharge of neurons. This is a surgically implanted electrode in the neck, and it's programmed to deliver the electrical impulses to the vagus nerve, referred to as the pacemaker of the brain. The patient can activate it with a magnet when he or she senses a seizure is imminent. Vagal nerve stimulation can cause adverse effects such as coughing, hoarseness, dyspnea, and tingling in the neck. Battery replacement is required via surgery about every 5 years. Ketogenic diet has also been effective in controlling seizures in some patients. The ketogenic diet is high-fat, low-carbohydrate diet. Ketones pass into the brain and replace glucose as the energy source. Biofeedback to control seizure teaches patient to maintain a certain brain wave frequency. So again, with the ketogenic diet, the ketones replace glucose as energy source. Ketones cross the blood-brain barrier and replace glucose as the energy source. The diet may be effective for some patients with drug-resistant epilepsy, but the long-term effects of the diet are not clear. Patients on this diet who use anticoagulants need close monitoring for bleeding. Biofeedback is aimed at teaching the patient to maintain a certain brainwave frequency that is refractory to seizure activity. Greater awareness of physiological functions connected to electrical sensors, and further trials are needed to assess the effectiveness of the biofeedback for seizure control. Nursing assessment. As always, we begin with the health history. So you need to ask your patient if there's any birth defect or injuries at birth, any anoxic episodes, CNS trauma or infections, stroke, metabolic disorders, or alcoholism. Subjective and objective data that should be obtained from a patient with a seizure disorder are presented in Table 59-11. Data related to a specific seizure episode can be obtained from a witness. You'll need to obtain a health history. This is a continuation of that health history that we started from the previous slide. You need to ask the patient if there's been an exposure to metals or carbon monoxide, hepatic or renal failure issues. Also ask if there's a compliance with anti-seizure medication, barbiturate or alcohol withdrawal, cocaine, or amphetamines. Medication. Adherence to anti-seizure medication regimen, barbiturate or alcohol withdrawal use, and overdose of cocaine, amphetamines, lidocaine, theophylline, penicillin, lithium, phenothiazines, tricyclic antidepressants, and benzodiazepines. All those are important to find out from your patient. You also need to obtain a family history. Ask if the patient is experiencing any headaches, aura, mood, or behavioral changes before a seizure, if they have any anxiety, depression, loss of self-esteem, or social isolation, if they're experiencing a decrease in sexual drive or experiencing erectile dysfunction. Precipitating factors are the metabolic acidosis or alkalosis, hyperkalemia, hypoglycemia, dehydration, and water intoxication. Remember, we have to correct the underlying problem to have no seizure occurrence. If a patient has a seizure, do they bite their tongue? Are there any soft tissue damage? Any symptoms or cyanosis present? Do they have an abnormal respiratory rate? Are they apneic, which occurs in the ictal phase? Are they absent or abnormal breath sounds? Is there an airway occlusion? Note if they're hypertensive, they're tachy or bradycardic, bowel and urinary incontinence, excessive salivation, if they're weakness, paralysis, ataxia, which occurs in the postictal phase, and abnormal CT, MRI, or EEG findings. And ataxia is difficulty coordinating or voluntary muscle movements. Nursing assessment, continue with the generalized seizure. If it's tonic-clonic, is there loss of consciousness, muscle tightening, then jerking, dilated pupils, hyperventilation, then apnea, and a postictal somnolence. Absence, altered consciousness, minor facial motor activity. Focal seizures. For our simple focal seizure, the patient usually reports the presence of an aura, a focal sensory, motor, cognitive, or emotional phenomena. It's a unilateral or marching, and it's a motor seizure. No change in awareness with the patient, abnormal movement or sensation limited to only one part of the body. Progresses in a predictable pattern, which is that marching that's listed there. Twitching or tingling in a finger or toe, and then or corner of a mouth, then marches over a few seconds to the entire hand, foot, or facial muscles. Focal seizures complex, altered consciousness with inappropriate behaviors and those automatisms. And those are the brief unconscious behaviors. They're simple and repetitive tics. And they will not remember the event, so amnesia is present. Nursing diagnosis, ineffective breathing pattern, ineffective self-health management, and risk for injury. Planning. Overall goals are that patient will be free from injury during seizure, have optimal mental and physical functioning while taking anti-seizure medications, and patient will have satisfactory psychological functioning. Health promotion will be to promote safety measures with this patient. Wear a helmet if there's a risk for head injury. General health habits include diet and exercise. Assist to identify events or situations precipitating seizures and avoid those if possible. Instruct to avoid excessive alcohol, fatigue, and loss of sleep. So improved approaches to perinatal labor and delivery care have reduced fetal trauma and hypoxemia, and thereby have reduced brain damage leading to seizure disorders for pregnant mothers or delivering mothers. Help the patient to handle stress constructively. During a seizure, airway, suction, oxygen, place patient on the side. No restraints. Do not restrain this patient. Monitor vital signs and neuro. Clean up the incontinence as quickly as possible. Document and report. Acute interventions: observe, treat, and document the seizure. Maintain patient airway, support head, turn to the side, loosen constrictive clothing, ease the patient to the floor. Do not restrain patient or place any objects in their mouth. The patient may require positioning, suctioning, or oxygen after the seizure. Avoid touching the patient during a seizure to prevent further stimulation. When a seizure occurs, the nurse should carefully observe and record the details of the event, because the diagnosis and subsequent treatment often rests solely on the seizure description. Note all aspects of the seizure. What events precipitated the seizure? When did the seizure occur? How long did each phase, oral, if any, ictal, postictal, last? What occurred during each phase? Both subjective data, usually the only type of data in the oral phase, and objective data are important. Note the exact onset of the seizure, which body part was affected first and how, the course and nature of the seizure activity, loss of consciousness, stiffening, jerking, total lack of muscle tone, the body parts involved, and their sequence of involvement, and the presence of autonomic signs such as dilated pupils, excessive salivation, altered breathing, cyanosis, flushing, diaphoresis, or incontinence. Assessment of the postictal period should include a detailed description of the level of consciousness, vital signs, pupil size, and position of the eyes, memory loss, muscle soreness, speech disorders, aphasia or dysarthria, weakness or paralysis, sleep period, and the duration of each sign or symptom. A seizure can be a frightening experience for the patient and for others who may witness it. Assess the level of their understanding and provide information about how and why the event occurred. This is an excellent opportunity for you to dispel many common misconceptions about seizures. Seizure response dogs. Did you know? Seizure response dogs receive special training to assist those in distress. They can help if the owner is in trouble. They can pull away objects that pose danger. They can carry information about their handler for emergency response teams, and they can provide emotional support. Do you know what to tell someone if they're interested in buying a seizure response dog? Here's what you should tell them. Contact Canine Assistance, one of the largest nonprofits that provide seizure response dogs. They actually specialize in seizure dogs. Understand the process. Although the cost to train a seizure response dog is up to $20,000 plus per dog, they provide the dogs free of charge to the recipients. The cost is covered by private donations to Canine Assistance. However, your patient will need to fill out an application and get on the waiting list. Complete the application. The application and the medical form needed is located on the Canine Assistant website. Mail to the address provided on the form. Consider getting on the wait list with a few organizations. If your patient is anxious about getting a dog, you can suggest they fill out applications for a few organizations. This will give you a better chance of finding a dog sooner. Pause with a Cause offers a program, and you can check the American Dog Trainers Network listings for programs in your state. Be patient while waiting for a dog. The wait list for seizure dogs can be a couple of years. Ambulatory and home care. Emotional support and identification of coping mechanisms to adjust to personal limitations imposed by the disease. Medical alert bracelets and referrals to agencies and organizations are a must. Patients with a seizure disorder also experience concerns or fears related to recurrent seizures, incontinence, or loss of self-control. For issues related to job discrimination, refer patients to the State Human Rights Commission or the State Department of Vocational Rehabilitation. Assist the patient who has specific problems in finding appropriate resources. You can engage the local chapter of Epilepsy Foundation, the Department of Veteran Affairs for Veterans, Community Mental Health Center for Intensive Psychologic Counseling, social workers, and welfare agencies for those with financial problems and living arrangement needs, vocational rehabilitation services for job placement when seizures are not well controlled, etc. Driving laws related to patients who have seizures vary from state to state. For example, for some states, they require a 3-month seizure-free period before issuing or reissuing a driver's license, whereas others require up to a full year. The EF provides current information on driving laws for each state. Inform the patient that medical alert bracelets, necklaces, and identification cards are available through the EF, local pharmacies, or companies specializing in identification devices, like Medical Alert. However, the use of these medical identification tags is optional. Some patients have found them beneficial, but others have found them to be more a burden than help because these individuals prefer to not be identified as having a seizure disorder. Encourage the patient to learn more about epilepsy through self-education materials. Evaluation. Expected outcomes. Experience breathing patterns adequate to meet the oxygen needs. Experience no seizure-related injury, and express acceptance of the seizure disorder by admitting presence of epilepsy and maintaining compliant behavior. So these are the expected outcomes of your patient. Evaluation. Again, acceptance of disorder, acknowledgement of the seizure has occurred, therapeutic drug level monitoring, compliance with the therapeutic regimen. Case study. So we're going to read this question and then you'll select the correct answer. So you are called to a patient's room by a patient's spouse when the patient experiences a seizure. Upon finding the patient in a clonic reaction, what do you think you should do first? A, turn the patient to the side. B, start oxygen by mask at 6 liters per minute. C, restrain the patient's arms and legs to prevent injury. D, record the time sequence of the patient's movements and responses as they occur. So what do you think? If you guessed answer A, you are correct. Rationale for answer A is during the seizure, the nurse should maintain a patent airway, protect the patient's head, turn the patient to the side, loosen constrictive clothing, and ease the patient to the floor if seated. The patient should not be restrained, and no object should be placed in the mouth. After the seizure, the patient may require repositioning to open and maintain the airway. Suctioning and oxygen should be right there. When a seizure occurs, the nurse should carefully observe and record details of the event because diagnosis and subsequent treatment often rest solely on the seizure description. Although important, it's not the first thing you should do.